And please, we've got posters that folks have worked so hard on, and it would be wonderful to get everyone back there to review the posters. It's my pleasure to introduce Dr. Schweng, and she is the director at JPS Healthcare Network in the United States. She received her Bachelor's of Science in Nursing from Texas Christian University and a Master's in Nursing from the University of Texas at Arlington. She is currently enrolled. This is done. You're not currently ready? When did you graduate? All right, a new DNP right here to my right. She is a certified emergency nurse, a Team Steps master trainer, and a Six Sigma Lean Green Belt. She oversees regulatory quality and safety for behavioral health at a large academic level 1 trauma center. The behavioral health department includes 136 inpatient psychiatric beds, a psychiatric emergency department, and nearly 20,000 visits annually. And it also includes 6 outpatient care clinics with partial hospitalization programs and an intensive outpatient program. Please help me in welcoming Dr. Schweng.
I'm not a very good note taker. That's why I had to work in the ED. All right, so my name is Amanda Schweng. Yeah, you know how you get report from ED nurses? Okay, yeah. All right, so there we go. All right, and so this was my DMP project that I did at Texas A&M University at Corpus Christi. I have to clarify that because I have an Aggie daughter, so you have to be sure that you say it right. Which one you went to? Yeah, whoop, yeah, we can all do it if you had one. Go there. All right, so this is the use of a violence screening tool to decrease workplace violence in an emergency psychiatric setting. And this here is my committee. All right, and so we all know about workplace violence, right? Everybody doing things about workplace violence in their organization, right? And so we've been talking a lot about workplace violence. Joint Commission came out with some standards in 2022. CMS is really getting on board. The government's trying to get OSHA to come up with some standards and things for workplace violence. Texas passed two laws into place at the last legislative session. So in 2023, the 88th one, one of them was kind of like the Joint Commission standards, but you had to have a prevention plan, you have to have policies, you have to have training, you have to do worksite analysis and things like that. And then the other one increased the penalty. And so healthcare workers comprise of 73% of all workplace violence instances that result in missed days of work. If you think about that, of all the different jobs, healthcare workers make up almost 3/4 of workplace violence injuries. I mean, that's crazy. And nurses in particular are punched, kicked, spat on, threatened, intimidated, hair pulled, and all sorts of things. And we know that workplace violence leads to physical injury, but it also leads to stress and emotional injury. Dr. Clark talked about instability and some of the things that happens with that. And so it leads to burnout, decreased morale, increased absenteeism, and of course, turnover. That's really hard to show, right? Because they don't always tell you that's why they're leaving. When it negatively impacts patient care, and it does this really in a couple of ways. One, if you think about it, if you have a really aggressive patient, it may take 5 or 6 staff to try to help control that one patient, and it pulls away from other patient care. There also is some time after the incident where staff have to debrief, whether that's formally or if they're kind of doing that on their own. That, of course, also takes away from patient care. And then what was talked about earlier this morning about incivility, about how it makes the staff member not as likely to go in and do good patient care. You have the same effects with workplace violence from patients. So this project really focused on the patient to staff type of workplace violence. There's 4 types of workplace violence, right? There's criminal intent, so somebody just comes on the campus for a crime. There's this type 2, this patient to staff workplace violence. Type 3 is the staff to staff incivility and bullying. And then type 4 is that relational. So that's what you think about like domestic violence, that it just happens because the person works in healthcare. All right. So here were the aims. The first one was to reduce physical assault by 10%. And physical assaults were used because the organization already had a really great data collection for workplace violence. But as we know, that's still really underreported. But there was a really good process in place to report physical assaults. And so that really became the focus to see if we really could reduce those because those were reliably reported. And then next was to reduce missed days of work by 10%. And the organization does a great thing. And I don't know if other people do this, raise your hands if you do. They pay staff time if they have to miss work due to workplace violence, whether it's from physical or emotional injury. So if somebody is affected by workplace violence and they need some time off, they pay them the actual pay until workers' comp kicks in. Anybody doing that? You're doing that, yeah. Talk to your leaders. It is, what we heard from staff. It is exceptionally insulting to have an injury and then to have to use your PTO, right? And so think about that. Those of you that can change things, and then if you can't, just keep talking about it over and over again, right? All right. And then next was to achieve 80% compliance with screening and interventions. All right, so the tool that we used was the DASA, the Dynamic Appraisal of Situational Aggression. Has anybody heard of that? Anybody using that tool? You're using? Okay, good. Anybody else using it? There's several violence screening tools for patients that can be used. The DASA is really well liked because it's easy to do. It only takes a minute or two. It's not actual questions that you ask the patient, but it's observations that the nurse makes. And so there's just 7 of those. And the research does show that an increase in that DASA score really does show an increase in aggression. And in particular, that 4 through 7. So the range is 0 to 7. There's 7 observations. Each one's 1 point. It's just yes or no. There's not like a range. So there's really a lot of great inter-rater reliability as well. And then if you do the screening and then do interventions for high risk, right? Hear me say, doing a screening with no interventions won't decrease workplace violence, right? So the screening is not enough. You have to have the interventions, and the interventions may even be more impactful. Nursing interventions on their own can help decrease workplace violence. Sometimes we think about things that the providers have to order, like emergency medications or force meds or restraints or seclusions, but there are things that nursing can do independently to help reduce workplace violence. And I really like this because there was a study that showed that using this tool, 77% of nurses felt they were better able to predict violence than just using their clinical judgment alone. And so before, that was what this group was doing, right? They're psych nurses. They really have a lot of experience. They're working in a psychiatric emergency setting. They really feel like they're really well equipped to recognize aggressive patients. And so I really like this, that this study showed that it helped people do that. All right, so this is just a little bit about the project. I reached out. Who was from Australia? That's where the author of the tool is from. So I actually had to call Australia because the emails wouldn't go through, from work, how they block them. And so they gave permission to use the tool for free, which is nice. And then I worked with the Epic EMR build team to create this and to embed it into the EMR. That really helps with compliance, and it makes it easier for the nurses. We really didn't want to create something that was more burdensome, and so the idea really was to make it as user friendly and as easy for them as possible. And then there was approval by the Nurse Advisory Council, and that just makes sure that it aligns with organizational goals. There's not something else that conflicts with any goals or things. All right, so a little bit about the setting. It's a level 1 trauma facility. The Psychiatric Emergency Center sees almost 20,000 people a year. That's a lot of people. It's real high acuity population. Approximately 60% of the patients are involuntary. That means that the police bring them in from the community, or they come in through the magistrate's warrant. So somebody's gone to court and got a magistrate's warrant for the mental health deputies to pick people up. About 40% come in on their own, voluntary. The length of stay for people that are admitted is only like 12 hours. There's really been a lot of work done to reduce throughput. And then the idea was to screen patients 12 years or age or older. There wasn't a lot of research about the validity of using this. on younger people. So what we did, we just went with what we did for suicide. We used suicide tool for 12, and so that just made sense here. All right, and then so here's the project intervention. I do want to say, like, this really is very inexpensive. There was no extra budget for this, right? There was a little bit of time for the staff, about 30 minutes with the frontline staff to be able to go through what the tool was and the intervention and show them the things. And then there was some things posted up and some time spent with the providers and security officers and some other folks. But it really is an easy tool. And so, as I said before, this is embedded in the EMR in the triage section, and it's towards the end. And so, for those involuntary people, that's a relatively long process in psychiatry. It can be 10 or 15 minutes. It's not like your minute or two triage. It's a little bit longer. There's a safety search and all sorts of things that go into that. And so the nurse really has spent a little bit of time. They also can use what collateral they have. So if they have something from the police when they come in or from family, they can use that information as well. And so if they so here's the 7 observations: irritability, impulsivity, if they've been unwilling to follow like simple directions, like if you're like, oh, come in this room, we're going to get you seen, right? And they don't want to do that. Sensitive to perceived provocation, if they're easily angered when requests are denied, have a negative attitude, or already having verbal threats. And so there you see, so it's 1 point apiece. Yes gets a point, 0 gets no points. The system automatically calculates it for you. All right, and so then 4, so if you have 4 of these, then you're considered high risk. Make sense? All right, and then so here are the interventions that were put into place. And I tell you, when we first started working with the team, with the leaders, with the nursing leaders of the unit, with the doctors, psychiatrists, and APPs, and the frontline staff and team leads and things, people were like, oh no, Amanda, like 50% of the people are going to be high risk. Like, what are we going to do? We can't have, it's going to be like the whole unit's high risk, right? And so these were the interventions that we came up with. There's not a lot of great research on interventions alone that work. And I think so many different populations are different that you kind of have to take and think about what kind of things can you do? What kind of resources do you have? Okay, so the first one was to notify the provider. And the idea when you notify the provider is the organization already had a PRN agitation order set. And so they already had where there was the MOAS tool. Anybody familiar with that? Modified Overt Aggression Scale. It's like 4 observations, but they're already aggressive. And so that was tied with medication, sort of like, well, kind of exactly like CEWA, where you do an assessment, you get a score, and then you have medication to give based upon the score. So there was that for the agitation order set contains that for agitation and anxiety. And anxiety, the GAD-7 was used. It is still used. And so you'd want to notify the provider, and then you'd want them to go ahead and order that. They didn't do that before, even though that was real common in inpatient. Every inpatient would have it if they'd been aggressive or not. But in the PsychED, because the doctors and the APPs are right there in the nurses station with the nurses, they did not order PRN med. So you would just go to the provider and say, hey, Amanda's getting agitated. Do you want to order something, right? Okay. And then the next was to notify the behavioral health security officer. So the unit already had 2 behavioral health security officers 24/7, which is really nice. Anybody in psychiatry? Yeah, you have security officers? Yeah. And so the organization has PD, has police, but these are security officers, so they're more like plainclothes. They're not as intimidating. And they develop a rapport with the patients. But their whole focus, while the nurses and techs have all these duties and things to do and assessments and things, their whole focus is on looking at safety, monitoring people, and looking for aggression at things. And so you'd want to notify the security officer, and then identification for the patient. So in the electronic medical record, it would be flagged if they were high risk. If you were looking at like the patient list, there was a column that had it was green, yellow, or red, right, for low, moderate, and high. And so that people would see if they went into the record that the person, what risk level they were. Because in these environments, the people are real mobile in the milieu. They're real ambulatory. And so we actually had where they wore a different color socks so that if you were walking about and you didn't know the patient, you didn't know their name, you could see that and then you would be alerted. I'm surprised at how controversial that is today. And so there's a lot of people that are like, that you have the question about, even when it's in the record, not even the different color socks, is about labeling patients, right? And there's a concern. Of course, psychiatric patients are not the only patients that are aggressive. Most psychiatric patients are not aggressive at all. But the staff deserve to know when someone is aggressive, right? And especially if they've already had a violent event. Right? It's a hard pill to swallow if on the shift before you, someone got punched in the face and then you walk out on the unit to go through and you have no idea because there's no identifier and there's no whatever. We really have to start talking about things and making a difference for staff. And so that was the identifier. And then the next was to provide a schedule for the patient. A lot of the research, especially in the emergency department settings, show that some of that wait time and not knowing what to anticipate causes some irritability and aggression for people. And so that was provided. They would go through and say, like, how long it would take before the doctor saw you, when the social worker may come, what time is the next meal, do you need a meal now, if there's any kind of music therapy or whatever may be happening during that day, that was provided to the patient. One of the things I want to mention about that agitation order set, when this was ordered early, it allowed the nurse, before the patient was aggressive or agitated, to be able to get the psychoactive medication consent. In psychiatry, they have to sign for all their meds unless it's an emergency. And so that would have to where the nurse would already have that in their back pocket. And so if the person began to where they exhibited some of those symptoms, they would have the medication, they would have already signed the consent, and they could simply go and say, hey, would you like me to get you something to calm down, and go through things. They'd already done the education, they'd already done all those pieces. All right, so here's what it looked like in the electronic medical record. You can see there, it's just real nice. It's clicky boxes, right? We like our clicky boxes now. And so you just click yes or you click no. The system totals it up for you and will say at the bottom what the level is. So for this one, it's 4, and then it does that for you, and then it does high for you. And then when it's high, it cascades those interventions, and then the nurse is to select which interventions they do. And so they pick those down there, and then it's all documented. And so here's the data collection. So the physical assaults were collected through the workplace violence entries that were in the data collection tool that already existed for workplace violence. One of the things I'd want to stress to you is it's really important to have that data as good quality data as you can. And so having someone validate that data is real important. So we have a workplace violence manager that does that now. Before that, it was other leaders that did that. But be sure to be mindful of that. What they do is go through and read those. And then if there's any duplicates, they remove them, right? Because you don't want to have more. And then they go through and make sure that it's as good as quality as it can be. And then the missed days of work was from Kronos. And then the DASA screening was from an EMR report. So here's the descriptive findings here. So you can see there was about over 4,000 patients that were screened during the time. And what I'll point out to you here down at the bottom is the risk levels. This was very surprising to people that the high risk was only 8%. And the staff, in this really high acute unit really felt that was going to be a lot of the patients were going to score high risk. It just shows us so much how that impacts staff, those patients that are aggressive, and how resource heavy they are. But as we look through, each time we ran the report, the numbers were about this. All right, so here are the results. So for physical assaults, we reduced those by 26%, which showed a statistical significance. And then for missed hours of work, this is real exciting. Remember, the organization pays people, so there's no reason not to take time off when you need it. Was reduced to 0 during the time. There wasn't a minute taken off work due to workplace violence. And then the compliance with the screening was 97%. Of those non-compliant, there was a handful, about 37, I think, by memory, people that did not have a screening. And then the rest weren't appropriate high-risk interventions. And those are my references. I have the red light, so I'll be quiet now and leave it for any questions.
Well, you're fine. You have an ER nurse, I know. Curiosity, what are you doing this screening tool? Is this something that they do just when the patient walks in, or is this something that's done? Obviously, patients escalate throughout their stay, especially if they're stuck with up to 5 days.
Yeah. Yeah, it's only done initially in triage, and what's done after is that modified overt aggression scale that's tied to the agitation order set. But they actually have to show aggression then, right? Because it's like aggression towards self, towards others, towards property, and verbal aggression. I think are the four things.
And also for modified.
Yeah, a lot of people, if you look at the research, a lot of people are doing it every shift or once a day, at least. But because there was already that other, we didn't want to add something on. So in the triage section, this replaced the MOAS, and then the MOAS was picked up as you had medications later on.
That was awesome. So I just wanted to say thank you for that. I wanted to mention something. So I'm sure you're aware, I'm not sure everyone is, that so in 2015, the American Nurses Association released a position statement on workplace incivility, bullying, and violence. It was time to update it because that's 10 years ago, right? So what they've done is they've separated those. The workplace violence statement, are you involved in that at all? Working on that?
No, I'm aware of it, but no.
Yeah, so the workplace violence one is almost done. It's been vetted with all of the nurses being able to give input, and it should be released very soon. I don't know that they have a date, but it's coming, and it should really be a wonderful resource for all of us. And then the incivility and bullying part of that, I'm a member of that team that's been assembled, and that one won't be available. I think our work is supposed to take about a year. But they're working very hard on all of these issues to support not only nurses. Certainly it's written for nurses, but it's for all workers in healthcare. And I wanted to mention one last thing. I had such a privilege to visit it was during Nurses Week a few years ago. I went to visit a psychiatric center. They said, when people visit our hospital, nobody ever wants to go to the behavioral health unit, but that's where you want to go? Okay, we'll go there. And one of the things that struck me almost immediately is their use of service dogs.
Mm-hmm.
And the dogs were trained to identify early agitation, early levels of anxiety, and the dogs. And I happened to be there when and it was in an adolescent unit. The dog went over to comfort and de-escalate the patient. It was one. I'm getting goosebumps even now thinking about it, and so I just think there's a place for canines to help us.
Yeah, we actually have the therapy dogs come into the psychiatric unit, both to the emergency one and inpatient. And people at first were like, "You can't do that." We've only had one instance where one of the patients thought that was her dog, and it became kind of a deal. But other than that, for years when they've been coming, there hasn't been any concerns, and I think it is just as beneficial for the staff as it is for the patients, because it's stress relieving for the staff as well. So yeah, they quit coming during COVID for some time, but yeah, they've started coming back now, which is
These dogs lived on the unit.
Oh, that's amazing.
That's what I didn't make that clear.
Yeah. Oh yeah, that's
Crazy.
Nice. Yeah.
Beautiful.
Nice.
Any other questions?